Welcome to lesson 4. This is one of the most important lessons in this entire course because we're focusing on opioids and overdose risks in this lesson. While the alcohol and the depressants they're carrying serious consequences and risks, opioids, this is one of the leading causes of overdose deaths, and that means that your understanding of this topic is directly tied to client safety in a very immediate way. So in this lesson, we're going to talk about how opioids are affecting the brain and the body and why they're so addictive, and more importantly, why they're so dangerous. And we're also going to spend a significant amount of time on overdose risk, and that's going to include like the factors that are increasing the risk and how they're going to show up in clients. You're going to learn about the traditional opioids and the newer synthetic opioids like fentanyl and the nitazines. These substances out there have really dramatically changed the landscape, and a lot of clients don't really fully understand what they're using. And that really is going to create situations where overdose is going to happen unexpectedly. So as we're going through this lesson, I want you to think about real world application. This is not just information, it's something that you're going to use to assess and educate and potentially save somebody's life. Understanding opioids is not optional in this field, it is essential. So opioids are a class of substances that's primarily used for pain relief. So they work by binding to the opioid receptors in the brain and the body. And these receptors are part of a system that's regulating pain and pleasure and certain bodily functions. And when opioids activate these receptors, they're reducing the perception of pain, and that can create a sense of euphoria or relaxation. And opioids include both legal and illegal substances. So we have the prescription opioids like oxycodone, hydrocodone, morphine. Those are commonly used in medical settings. Illegal opioids are heroin or synthetic substances like fentanyl. And we're going to see those out on the streets a lot more than in a traditional clinical setting. They do use fentanyl in clinical settings, though. So from a pharmacological standpoint, these substances are going to work in similar ways, even though the sources are going to differ. And one of the key characteristics of opioids is their high potential for addiction. So, that's really due to their effect on the brain's reward system, particularly our dopamine reward system. And we know that they don't only just relieve pain, but they also create this really strong reinforcement pattern that's going to encourage repeated use. So maybe the clients start using opioids for legitimate medical reasons, but then over time, that use is going to shift into misuse, and then that's going to lead to dependence. And understanding this progression is critical for assessment and treatment. So we can group opioids into a couple of categories based on what is their source and what is their composition. So the prescription opioids are commonly used for pain management, and they include medications like oxycodone, hydrocodone, and morphine. So these are often the starting point for a lot of clients. Heroin, this is an illegal opioid that's derived from morphine. So it's often used when like the client can't get prescription opioids anymore, or the prescriptions become a little bit too expensive for them. The heroin use is going to carry significant risks like overdose and infection. And then the synthetic opioids, these are newer, and it's an increasingly dangerous category of opioids. These are going to be your fentanyls, the substances in the nitazine classes like carfentanil, iso. And these drugs are a lot more potent than the traditional opioids. And that's going to significantly increase the risk of overdose. And one of the biggest challenges with these synthetic opioids is that the clients often don't know that they're using them. Because fentanyl and like the other substances that are similar to fentanyl, they're frequently mixed in with the other drugs. So that means that the client may believe that they're using one substance when they're actually using something that's a lot stronger. And understanding these categories is going to help you assess your risk or the client's risk and educate the clients more effectively. So opioids, they're going to affect the brain by binding to the opioid receptors. And those receptors are located in the areas that are responsible for pain, reward, and basic life functions. So when these receptors are activated, they're going to reduce the perception of pain, and they're going to create a sense of relief or a sense of euphoria. And then at the same time, the opioids are going to increase the dopamine levels, and that's going to reinforce that behavior and encourage repeated use. And that's the part that makes the opioids so addictive. The brain starts to associate the opioid use with relief and reward. And we know that opioids are going to slow down the bodily functions like breathing. And so that's a really key factor in overdose risk. When too much of the substance is present, the breathing can slow to the point where it stops. And understanding these mechanisms is going to help you recognize both the appeal and the danger of opioids. Now, I know we already talked about tolerance, but I want to kind of hit back on this again because tolerance develops quickly with opioid use. And that means that clients need higher doses to achieve the same effect in a relatively shorter period of time. And that rapid progression is one of the reasons that opioids are so dangerous. As their tolerance is increasing, so does the amount of the substance that they're using. And that's going to increase the strain on their body, and it's going to raise the risk of overdose. And clients may not realize how quickly this progression is happening, honestly. Another important factor is that tolerance to the euphoric effects may develop faster than the tolerance to the respiratory depression. So that means that the client may feel less high, but they're still at a higher risk for overdose. So as a counselor, recognizing tolerance patterns is going to help you to assess risk and progression. And one of the most dangerous aspects of opioid use is the loss of tolerance after a period of abstinence. So they quit using, and maybe the client's been in treatment or they've been incarcerated or just not using for a period of time. And during that time, the body's readjusting and it's becoming more sensitive to opioids. And if the client returns to using at their previous dose, the body may not be able to handle that. And that dramatically increases the risk of overdose. They just go back out there and they're like, oh yeah, I was using like 4 pills, and that 4 pills leads them to an overdose. This is one of the most common scenarios in fatal overdoses, because the clients believe that they can use the same amount as before, but they don't realize that their tolerance has changed. So as a counselor, this is a very critical education point. The clients need to understand that their risk is highest after a period of not using. And fentanyl is one of the most important substances that you need to understand as a counselor because it has significantly changed the landscape of overdose risk. Fentanyl is a synthetic opioid that's much more potent than the traditional opioids like morphine or heroin. So it's been estimated to be like 50 to 100 times stronger than morphine. And that means that even a very small amount can have a very powerful effect on the body. And one of the most dangerous aspects of fentanyl is that it's mixed in with other substances. So the clients believe that they're using heroin or cocaine or even like counterfeit prescription pills. But in reality, the fentanyl is present there. And that dramatically increases the risk of overdose because the person's not even aware of the strength of what they're using. And fentanyl acts so quickly. It binds to those opioid receptors and it starts to depress the central nervous system almost immediately. And that rapid onset leaves very little time to respond if the overdose occurs. I mean, they use it to put people to sleep for surgeries. Like, think about how fast you go out in a surgery. So from a clinical perspective, you need to assume that fentanyl may be present in any illicit drug use. That's really important when you're assessing risk and educating clients, because a lot of clients don't realize how common fentanyl has become. And I mean, I have personally known someone that was using marijuana, and he didn't realize that somebody had put fentanyl in the marijuana, and he overdosed and passed away, and he was only 18 years old. So understanding fentanyl is not just about knowledge, it's about prevention. When we can educate clients about fentanyl, we're giving them information that can potentially save their life. And beyond fentanyl, there's even more potent synthetic opioids that are coming out, carfentanil and the nitazines. And carfentanil is extremely powerful. and it was originally developed for use in large animals like elephants. It is significantly stronger than fentanyl, so that already carries a high risk of overdose. The nitazines, these are a newer class of the synthetic opioids that have been increasingly identified in the drug supply. And a lot of times we didn't know that these even existed, so there wasn't any testing for it, and people were overdosing on these, and they were doing, you know, the autopsies, and they weren't even testing for it. Now we know, right? And so these are included in autopsies. But these substances, we don't understand them well. The general public doesn't understand them well. A lot of professionals are still learning about them. But what's clear is that they are really, really highly potent, and they're going to carry a significant risk of overdose. I mean, if fentanyl is 50 to 100 times more powerful than morphine, carfentanil is going to be 1,000 times more powerful. And then iso, which is one of the nitazines, is even more powerful than the carfentanil. So one of the challenges with these substances is, as I said, they're mixed in with the other drugs, and the user doesn't know. And that creates this unpredictable and dangerous situation. The client may use the same amount that they've used before, and they don't realize that the potency has changed. So as a counselor, we don't have to be an expert in every emerging substance, but we do need to understand the trend. The drug supply is becoming more potent and less predictable, and that's going to increase the risk across the board. So educating our clients about these substances, even at a basic level, is going to help them understand why overdose risk is so high and why caution is critical. So opioid overdose happens when the substance overwhelms the body's ability to function, particularly the respiratory system. And so, as I talked about earlier, opioids slow down the breathing. And if it's an overdose, this effect becomes severe enough that the breathing is slowing significantly, or it's just going to stop altogether. And when the breathing slows down, the body's going to receive less oxygen. And this lack of oxygen, it's going to affect the brain very quickly. Within a few minutes, the brain is going to start to suffer damage due to the oxygen deprivation. And that's why overdose is such a time-sensitive emergency, because as the oxygen levels are dropping, the person may become unconscious. They might appear to be sleeping, but they're actually in a dangerous state where their body's shutting down. And without intervening, that leads to death. And one of the most important things to understand is that overdose is not always dramatic. It happens quietly, especially if the person's alone, or maybe they appear to be resting. And that's what makes it even more dangerous. So as a counselor, understanding what happens during an overdose helps you to educate the clients and emphasize the importance of prevention and also how to respond. So recognizing the signs of an opioid overdose is really critical because it's going to allow for timely intervention. And one of the most important signs is slow or absent breathing. So that may look like shallow breaths or maybe long pauses between the breaths. And another key sign is a change in their skin color, particularly if they have like blue or gray lips or fingertips, because that's going to indicate a lack of oxygen in the blood. Maybe the person's unresponsive, meaning like they're not waking up when they're spoken to or they're touched. Maybe they're making a gurgling or a choking sound. That's another warning sign that can occur when the airway is partially blocked. And these sometimes are referred to as a death rattle sound and should always be taken seriously. So as a counselor, you may not be the one that's responding to the overdose, but you can educate clients and their families about these signs because this knowledge is going to save lives. Now, I always educate my clients on naloxone, which is also known as Narcan. It's a medication that reverses opioid overdose. It works by binding to the opioid receptors, and it blocks the effects of the opioid. And that restores the breathing and the consciousness if you administer it in time. And one important thing to understand is that naloxone is temporary. It may wear off before the opioid has fully left the system. And that means that medical attention is still necessary even after naloxone is administered. And this is widely available in a lot of areas, and people can carry it, individuals, families, community members. And as a counselor, you need to be aware of where it can be obtained and encourage clients who are at risk to have access to it. There are certain community partnerships that will give it away for free. They can get it through their insurance at the local pharmacy, or they can pay cash for it at the local pharmacy and get it over the counter. You don't need a prescription for it. But educating the clients about naloxone is just a really practical and potentially life-saving intervention, and it empowers them to respond in emergency situations. It's typically given in a nasal spray, so the pack will come with 2, and you'll lay the client flat on their back, and you'll tilt their head back so that their neck is flat, and then you will administer 1 dose in the nose, and then you wait. And if they haven't come back to within, a couple minutes, then you can give the other dose of the naloxone. And you're calling 911 and giving the dose at the same time. You really just want to give the dose first and call 911. But that person that's having the overdose, they're going to benefit from the urgency of the emergency vehicle getting there quickly, because they may have more naloxone that will keep them alive until they can get them to the hospital. Now, I do want to talk about xylazine, and this is disgusting. This is an emerging substance that is increasingly being found in combination with opioids, particularly in combination with fentanyl. It is not an opioid. It's actually a veterinarian sedative, and it's going to produce very strong sedative effects. And that contributes to the overdose risk. And the reason why I'm putting it in with the opioids is because it's typically found in combination with opioids. And one of the most important things to understand about xylazine is that it is not reversed by naloxone. Narcan's not going to help, right? So even if you do give the dose of naloxone, the person may still remain sedated or unresponsive because of the presence of the xylazine. And this is more potent and prevalent in areas like Pennsylvania and the eastern coast. But xylazine is associated with severe skin wounds and overall health complications. And they're still studying this, but this represents an additional layer of risk. And that's because it causes a flesh-eating bacteria. And not just in the site that it was administered. So even if they are using intravenous methods to administer it, it can affect you somewhere else on your body. These sores are gruesome. So we need to be aware of these substances like xylazine, because they're changing how overdose presents and how it's managed. And that's going to reinforce the importance of staying informed about these emerging trends. So these wounds often start as small purple blisters or bruises, or maybe even like pinpoint holes, and they're going to quickly get worse into these large, open, deep ulcers. And then a hallmark of these wounds is the presence of like yellow and black necrotic tissue. Necrotic means dead. And sometimes that causes a mummified appearance of the limbs. And these wounds, like I said, appear anywhere on the body, not just the injection site. And they're frequently seen on the arms and legs, but they can occur on the back and the chest and other areas. And these wounds are accompanied by a very strong foul odor and significant discharge. And they tend to heal very, very slowly. So just understand that xylazine is a very potent vasoconstrictor. It means that it restricts the blood flow to the skin, and that causes the tissue to die, which is called ischemia. And it's believed that the drug has a direct toxic effect on tissues, which we call cytotoxicity. And that causes localized damage that's very similar to a chemical burn. And, it's often associated with injecting trank, which is what xylazine is called. But these wounds can appear in people who smoke it or snort it. So if you hear your client talking about using trank or the zombie drug or xylazine, that's all the same substance. So polysubstance use is one of the most important factors to assess when we are working with clients who use opioids, because the opioids alone are going to carry a high risk of overdose. But when they start combining them with other substances, it's going to dramatically increase their risk. And one of the most dangerous combinations is opioids with alcohol, because both of those substances are depressing the central nervous system, particularly the respiratory system. And when they use it together, it's going to suppress their breathing, almost to a fatal level much more quickly than just using either substance by itself. And then another high-risk combinations is opioids with benzodiazepines like Xanax or Valium. Like I said in the last lesson, benzodiazepines act on the GABA system, and that slows down the brain activity. And when it's combined with the opioids, the effects of on the person's breathing are amplified. And so that's one of the leading causes of overdose deaths. So maybe we encounter a client who's using opioids with stimulants. They call that speedballing. So you have the downer and the upper at the same time. And that creates a different kind of risk. So the stimulant may be masking some of the sedating effects of the opioid, and that leads the person to use more than they otherwise would. But once that stimulant wears off, the full depressant effect of the opioid can take over, and that increases the risk of the overdose. And the client doesn't understand these interactions, and they may view each substance separately or fail to recognize the combined risk. So as a counselor, it's critical for us to assess for all substances, not just the primary drug of concern. And understanding the polysubstance use allows you to identify high-risk patterns and provide targeted education. And this is one of the most important ways that you can reduce harm and improve client safety. So we know overdose doesn't happen randomly. There are specific factors that significantly increase the risk, and understanding these factors is critical for both assessment and prevention. And one of the most important risk factors is a loss of tolerance. So like I talked about earlier, when the person stops using for a period of time, their body becomes more sensitive to the opioids. And if they return to using at that previous dose, the risk of overdose is going to be extremely high. So using alone is another major risk factor. When that person's alone, there's nobody there to be able to recognize the signs of overdose and administer the naloxone. And that's going to increase the likelihood that the overdose is going to be fatal. Unknown substance potency is also another significant concern, especially with the presence of fentanyl and the other synthetic opioids. The clients believe that they're using a certain substance, but the potency may be higher than they expected. And then mixing the substances, that's particularly with other depressants, that's going to further increase the risk. It's creating that compounded effect on the central nervous system, especially their breathing. And recent detox or incarceration is another high-risk period because during those time periods, the tolerance is going to decrease, but the client doesn't really adjust their behavior accordingly when they resume use. So as a counselor, we need to identify these risk factors, and that's going to allow us to prioritize safety and provide targeted education. That's where your knowledge has a direct impact on the outcomes. So let's look at a common and tragic scenario. A client is released from jail after a period of abstinence, and during that time, their tolerance to opioids has decreased. But then they return to use, and they take the same dose that they were using before they were incarcerated. And from the client's perspective, this feels like a normal decision. They're returning to a familiar pattern. But from a pharmacological standpoint, their body's no longer able to handle that dose, and the result is a high risk of overdose. And this scenario is one of the most common in fatal overdoses. It's highlighting the importance of understanding tolerance and how quickly it changes. And it's also emphasizing the need for education during high-risk transition periods. So as a counselor, you may work with clients before or after these transitions, and that's going to give you an opportunity to provide some critical information that can help reduce their risk. Explaining the concept of tolerance in a clear and practical way is going to make a huge difference in how the client responds. And this case also really just reinforces the importance of not assuming that the clients understand these risks. Even people with long histories of use may not fully grasp how their tolerance has changed. And then another increasingly common scenario is going to involve fentanyl exposure. The client believes that they're using a prescription pill like oxycodone, but the pill is counterfeit and it contains fentanyl. So the client takes what they believe is a typical dose, but then the potency is much higher than expected. And because the fentanyl is so strong, even a small amount leads to an overdose. And that client may not have had any warning signs before they started to experience severe respiratory depression. And that's going to make the situation particularly dangerous. The client's often trusting the appearance of the pill, and they believe that, hey, this looks like prescription medication, so it must be safe. But unfortunately, the counterfeit pills are widespread, and the appearance is not as reliable of an indicator of what it contains. So, as a counselor, you need to educate clients about this reality, because a lot of people are unaware of how common fentanyl contamination has become. And that knowledge can influence their behavior and reduce their risk. And this really just highlights how overdose risk is not always about intentional misuse. Sometimes it's just a lack of information and an unpredictable substance composition. And we know that certain clients are higher risk for overdose based on their history and their patterns of use. And a history of overdose is just one of the strongest predictors of future overdose. And that indicates that the client has already experienced a high risk situation. High tolerance, that's another factor. While it may allow the clients to use larger amounts without feeling as impaired, it also increases the likelihood of escalating that use and the likelihood of a potential overdose. And polysubstance use, that significantly increases risk, especially when the opioids are combined with the depressants. And that's going to create that compounded effect on the body. Recent abstinence, like I just discussed, that's also another critical risk factor. Clients who have been in treatment or incarcerated or otherwise who are not using, they're at risk, higher risk when they resume their use. So as a counselor, recognizing these patterns, it's going to help you to prioritize interventions and focus on safety. So your role as a counselor is going to include overdose prevention, even if you're not providing medical care. One of the most effective ways to reduce risk is through education. Clients need accurate, practical information about substances and their effects. Assessment's also going to be critical. You should regularly be evaluating risk factors and adjusting your approach as needed. People's lives change all the time. This is not just a one and done, right? It is an ongoing process. So encouraging access to naloxone, that's another key intervention. Clients and their families should know how to obtain it and how to use it. Promoting safer behaviors, such as not using alone, that can also reduce risk. And while abstinence may be the goal, harm reduction strategies are another important part of care. So, talking to clients about overdose risk might feel uncomfortable, especially if you're worried about sounding harsh or like you're being alarming or confrontational. But it's one of the most important conversations that you can have with a client who uses opioids. The key is to be both direct and respectful. The clients need clear information, not just vague hints or overly softened language that minimizes the seriousness of the issue. At the same time, they also need to feel that you're talking with them, not talking down to them. So a good approach here is to focus on safety rather than shame. So, for example, instead of saying, you're being reckless, maybe you want to change that to like, I want to make sure you understand how high the overdose risk is right now, especially with fentanyl in the drug supply. And that keeps the conversation grounded in facts rather than blame. And it also makes it more likely that the client's going to stay engaged instead of shutting down. And another important point is that overdose education usually needs to be repeated. A lot of clients don't fully absorb it the first time, especially if they're ambivalent about, what their change is. That doesn't mean that the conversation is not valuable. It just means that, repetition is part of the process. You may find yourself reviewing the same safety information several times over the course of treatment. And that's appropriate. That's necessary. And it's also helpful to be specific. Rather than saying, be careful, just explain what actually increases the risk. It's Talk about using alone. Talk about reduced tolerance. Talk about counterfeit pills, fentanyl contamination. Talk about mixing opioids with alcohol, or opioids with benzos. The more concrete that you are, the more useful the conversation becomes. And as a counselor, your role is not to control the client's decisions. Your role is to make sure that they are informed. And as a counselor, your role is not to control the client's decision, it's to make sure that they make informed decisions. So we're providing accurate, practical information in a calm and respectful way, and we're increasing the chances that the client's going to make safer choices. And that matters. Even if they're not yet ready for the full abstinence, the conversations are not just educational, they're preventative and they can save lives. Now, harm reduction is a really important concept in opioid counseling because it's addressing the reality that not every client is immediately ready or able to stop using. In those situations, reducing the likelihood of death or severe harm becomes a really critical goal. Harm reduction doesn't mean approving of substance use. It means acknowledging reality and taking practical steps to help keep people alive long enough to have a chance at recovery. And one of the most important harm reduction tools is naloxone. Clients at risk for opioid overdose should be encouraged to carry it, and the family members and the friends should also know how to use it as well. And another important strategy is encouraging clients not to use alone. And while this may not eliminate the risk, it's going to increase the chances that somebody will be present to respond if an overdose occurs. There are test strips where these are available and legal, and they can be part of the harm reduction conversation. These tools may help identify fentanyl in substances. It doesn't necessarily guarantee safety, though, but it's just simply one more layer of risk reduction. Another key message is the importance of seeking emergency help quickly. Some people hesitate to call 911 because of fear or shame or legal concerns. So clients need to understand that delayed response can mean the difference between life and death. And it's also important to clarify that harm reduction is not the same as encouraging use. Some counselors struggle with this concept because they worry that it sends the wrong message. In reality, providing safety information is part of responsible care. So telling a client how to reduce overdose risk is no different than educating somebody about seatbelts or CPR. It's a safety measure. And as a counselor, you can hold both truths at the same time. You can support recovery goals and still provide harm reduction education. And these approaches are not opposites. They're both part of meeting the clients where they're at while prioritizing survival and stability. In opioid work, that balance is going to be essential. Now, opioid withdrawal, this is another major factor in ongoing use, and it's something that clients talk about often because of how intense and distressing it can feel. Unlike alcohol or benzodiazepine withdrawal, opioid withdrawal is usually not fatal on its own, in otherwise healthy adults. But that doesn't mean that it's minor or it should be dismissed. It's often extremely uncomfortable and it can feel unbearable to the person who's experiencing it. So common symptoms may include muscle aches, sweating, chills, nausea, vomiting, diarrhea, anxiety, agitation, insomnia, and also intense cravings. The clients may describe feeling like they have the flu, but much worse. And, back in the day, Viktor Frankl said, you better hope it's opioid withdrawal and not the flu, because the flu will kill you. These clients are describing a really profound sense of restlessness or physical misery that's driving them to seek relief immediately. And that's one of the reasons opioid use can become so repetitive and compulsive. The person may continue using not because they're chasing the euphoria, but because they're trying to avoid the withdrawal. And it's really important to clearly distinguish opioid withdrawal from alcohol withdrawal. in your teaching and your assessments because they're two totally different things. And I also make the point that every drug has its own different withdrawal symptoms. So when I say the word withdrawal, most people go to opioid withdrawal symptoms when I ask them what it is. But withdrawing from cigarettes or marijuana is going to be different than alcohol and benzodiazepines, and that's going to be different than opioids. They just view the word withdrawal generally, and they don't really understand that some forms are medically more dangerous than others. And like I said, opioid withdrawal, not usually life-threatening in the same way that alcohol withdrawal can be, but it still matters a lot because it does affect their behavior and their motivation, and it's affecting their relapse risk. So as a counselor, understanding opioid withdrawal is going to help you interpret client behavior more accurately. A client who's irritable or distressed or desperate may not just be resistant. They may just be trying to function while they're in withdrawal or while they're anticipating the withdrawal. And, that's not eliminating their responsibility, but it's giving an important context. And this is also an area where referrals are going to matter. The clients may benefit from medication-assisted treatment, detox support, or medical consults. So your role is not to manage withdrawal medically, but to recognize what's happening and assess the level of need and connect the client with appropriate care. And this understanding is going to improve both empathy and clinical effectiveness. So when you're working with a client who's using opioids, it's really important to recognize the common symptoms of withdrawal because, those symptoms are going to shape the client's behavior and their mood and how engaged they are in the treatment process. And we know that muscle aches are really common, and the clients are going to describe feeling sore and restless and unable to get comfortable. They are going to experience sweating and chills, and that's going to happen in cycles. And that's going to make the person feel physically miserable and dysregulated. Gastrointestinal symptoms are going to be common and severe. Nausea, vomiting, diarrhea, and that can wear a person down physically really quickly. And the symptoms may also start to contribute to dehydration and exhaustion. And then there's the anxiety and the agitation. That's another major part of the opioid withdrawal. The client may appear restless or irritable or unable to settle down. And we can misread this as attitude or resistance if we're not recognizing what's happening. And then insomnia is going to add another layer of distress because when this person's exhausted and they're unable to sleep, their ability to cope drops down even further. And then on top of all of that, the cravings tend to intensify. And so the person's not only physically uncomfortable, but they're also strongly pulled toward using as a way to stop the symptoms. So it's important to understand that withdrawal symptoms are not just background information. They are active drivers of this client's behavior. They're going to influence the motivation and the decision making, whether the client's being honest or attending or following through. Maybe they're missing appointments or struggling to focus, or maybe they just seem emotionally volatile because they're in withdrawal or they're trying to avoid it. So as a counselor, we need to listen carefully for these symptoms in the client's own words. So they may not say, I'm in opioid withdrawal. Instead, they might say, I'm sick, or I can't stop sweating, or I can't sleep and my legs won't stay still. And your job is to connect those descriptions to the underlying pharmacology and respond appropriately. That's what turns knowledge into practice. And honestly, I would send somebody like that to detox. So medication assisted treatment would be another referral that I would send them to. MAT treatment is one of the most important areas for opioid counseling because it's directly affecting withdrawal and cravings and relapse risk and overdose prevention. The counselors don't prescribe these medications, but you absolutely need a working understanding of them because a lot of your clients will either be on them, considering them, or asking about them. Methadone, this is a full opioid agonist. This is used in highly structured treatment settings, and it's going to help the client to reduce their withdrawal symptoms and cravings because it's activating opioid receptors in a controlled way. Buprenorphine or Suboxone, um, when it's combined with naloxone in Suboxone, it's it's a partial opioid agonist, and that means that it's acting on the opioid receptors, but in a way that's generally carrying less overdose risk than full agonists when they're used as prescribed. And naltrexone is going to work differently. It's an opioid antagonist, which means that it's blocking the opioid receptors instead of activating them. And each of these medications has a different purpose, a different structure, a different clinical fit. So it's important not to lump them together as if they're all the same. Clients may have really strong opinions about MAT treatment based on maybe the stigma, or maybe they're misinformed, or they've had prior experiences. They may say things like, oh, that's just replacing one drug with another. And then other people may be very interested in MAT, but they don't understand the difference between the medications. So as a counselor, your role is not to tell the client what medication to take. Your role is just to understand enough to support informed conversations and reinforce appropriate referrals. You should be able to explain the basic differences and challenge any myths in a respectful way and encourage collaboration with qualified medical providers. This is kind of an area where the counselor's attitudes matter a big deal. You know, if you carry stigma or misinformation about MAT treatment, then that's going to affect the client outcome. But if instead you're approaching it with accuracy and openness, then you're going to create space for more effective treatment planning in opioid work, and that can make a major difference. So, like I said, methadone, this is a full opioid agonist. So it's fully activating the opioid receptors in the brain. And because of that, it reduces the withdrawal symptoms and the cravings very effectively. And in treatment settings, methadone's used to kind of control and we're giving it to them in a structured way to stabilize the client, because they may continue to cycle through their use and withdrawal and relapse. And one of the strengths of methadone is that it's very effective for clients with long-term or high-intensity opioid use, because it helps them to function more consistently and reduce the illicit use. And that's going to improve treatment engagement. But because it's a full agonist, it's also going to carry risks, especially if it's misused or it's combined with other depressants. Methadone is usually dispensed in regulated treatment programs rather than just prescribed casually. And that structure is important, and it can actually be helpful for a lot of clients, especially when they need routine and monitoring and support. And some clients may resist methadone because of the stigma, or they've heard negative things about it. And other people see it as the first thing that has ever helped them feel stable. So as a counselor, you need to understand both the benefits and the limits of methadone. You don't need to explain every medical detail, but you should know that it's a legitimate treatment tool and not just a substitute drug. It's going to lower the overdose risk. It's going to reduce chaotic use patterns, and it's going to help the client engage more effectively in counseling and in their life responsibilities. So if a client is on methadone, that should be part of your assessment and treatment planning. You need to be aware of how it fits into their recovery plan, how they're looking at it, and what kind of challenges that they're facing. Because accurate understanding is going to help you support clients without reinforcing the stigma. And then buprenorphine is another major medication that's used in opioid treatment. And it's especially important because it is widely used in office-based settings. It is a partial opioid agonist. And that means that it's going to activate the opioid receptors, but not to the same extent as a full agonist like methadone. And that gives it an important safety feature we call the ceiling effect. At a certain point, the opioid effect levels off, and that's going to lower the risk of the respiratory depression compared with the full agonist when they're taken as directed. Suboxone is a common brand name that combines buprenorphine with naloxone. And the naloxone component is generally introduced to reduce the misuse by injection. So clients may know these medications by brand name or street name, or maybe have partial information. So it's important to ask clearly and specifically what they know. Buprenorphine is really effective for reducing cravings and withdrawal symptoms, and that helps the client to stabilize and engage in the treatment. But it's going to often allow people to function more normally in work and family life and counseling. And that stability can create the space needed for behavioral and psychological change. Some clients feel shame about taking Suboxone because they believe that it means that they're not really sober. And others may fear becoming dependent on it. And these concerns are common, and they should be explored with respect rather than dismissed. And then at the same time, misinformation needs to be addressed clearly. A client using prescribed buprenorphine as part of the treatment is not the same as a client engaging in uncontrolled illicit opioid use. So, as a counselor, your role is to support accurate understanding and help the clients integrate MAT into their broader recovery work if they're choosing that path. And that means addressing stigma and helping with expectations and reinforcing the idea that recovery is not this one-size-fits-all thing. Buprenorphine is not a cure, but it can be a very effective treatment tool. And naltrexone works very differently from methadone and buprenorphine. It's an opioid antagonist, which means that it blocks the opioid receptors rather than activating them. And the way that I remember this is anti means against, so it's stopping it from happening. So antagonist means that it's blocking the receptors. And if the opioids are used while naltrexone is active, then the person's not going to experience the expected opioid effect. And that can make it it's a useful relapse prevention tool for some clients. But naltrexone requires a very important condition. The client needs to already be detoxed from opioids before they start it. Because if they take it too soon, it triggers precipitated withdrawal. And it's sudden and it's extremely uncomfortable. And because of that, the timing and the medical oversight are essential. Now, naltrexone may be available in oral form or as a long-acting injection. Some clients prefer it because it's not an opioid-based medication. Others find it difficult because it doesn't relieve cravings or withdrawal in the same way agonist medications do. And that means that it may work well for some clients and poorly for others. So as a counselor, it's useful to understand why a client or provider might choose naltrexone. And, maybe it fits better for clients who have already completed detox, who prefer a blocking medication, or who have certain treatment goals or legal circumstances. Maybe it's less effective for clients who are unable to get through detox or who need stronger craving control. Again, your role is not to prescribe or recommend specific medications. Your role is to understand enough to support treatment planning conversations and avoid spreading inaccurate information. A clear understanding of naltrexone is going to help you to do that more effectively. I do want to talk about kratom for a second because this is worth including in this lesson because a lot of clients don't look at it as an opioid-related substance, even though it does produce opioid-like effects at higher doses. And it's marketed as natural or herbal, and that leads a lot of people to assume that it's automatically safe. And in reality, kratom can affect opioid receptors, and it may be caused, or used by clients for like pain relief or its various mood effects, or maybe they're attempting to self-manage their withdrawal. Whatever the case, some clients use kratom as a form of self-detox. They may say that they're using it to stay off of pills or heroin. And then others may use it because it's easier to obtain or because it feels less stigmatizing than traditional opioids. And while those motivations are understandable, kratom's still going to carry risk, and that's going to include tolerance, dependence, and withdrawal. And the clients minimize the kratom use because it's sold in stores, sold online. You can get it in the gas station. And they say, oh, it's just a plant, or it's not a real opioid. So as counselors, we need to move beyond the labels and just focus on the effect. If it's acting on opioid pathways and affecting behavior or dependence patterns, it belongs in the clinical picture. Assessment is especially important here because clients may not disclose kratom unless you ask them directly. If you only ask about heroin or fentanyl or pills, you might miss it. And you also need to pay attention to why the client's using it. If they're self-treating pain or withdrawal or emotional distress, that's going to tell you something important about what their risk is and what their treatment needs are. So including kratom in this lesson is just reinforcing this larger point that substances don't have to be prescription only or illegal to matter clinically. Our job is to understand the effect and the pattern and the risk, and kratom fits squarely into that framework. And sometimes counselors understand the material well, but they struggle with how to explain it to clients in a plain language. And so this is about practical translation. If you're explaining loss of tolerance, maybe you might say, when you stop using for a while, your body's going to reset some. And that means the amount that you used before can become dangerous and even deadly if you go back to it. That's simple, that's clear, that is clinically accurate. If you're explaining fentanyl contamination, maybe you might say something like, a lot of street drugs and counterfeit pills now contain fentanyl, and people don't know that it's there. And that means that the strength is unpredictable, and overdose can happen even when somebody thinks that they're taking their usual amount. So again, the goal is clarity, not complexity. If you're emphasizing not using alone, maybe you say, if nobody's there, no one can respond if you stop breathing. That's a direct statement, but it is grounded in safety. Clients need information explained in a straightforward, real-world way rather than formal clinical language. So as a counselor, this kind of education matters because it's bridging the gap between the pharmacology and the actual behavior. The clients are more likely to remember information that feels concrete and practical. They don't need a lecture on receptors and neurotransmitters every time. They need language that they can connect to real choices. And that's where repetition is going to matter. You may need to go over the same points multiple times in slightly different ways. That's not a failure. It's part of effective counseling. And good education is often simple, direct, and repeated. And that's especially true in opioid work where misunderstanding can have fatal consequences. And there's certain clinical red flags that we need to immediately increase our concern on when we work with clients who use opioids. And one of those, the most recognizable, that's nodding off, especially during sessions and while they're trying to speak. That indicates active opioid effect and heavy sedation. And then we have constricted pupils. That's another classic sign. They should never be used alone to draw conclusions, but they're just simply a piece of the picture. We may see track marks or known injection history. That's going to raise a concern because injection use carries additional risk like overdose, infection, abscesses, bloodborne diseases, and a repeated overdose history is one of the most serious red flags of all. If a client's overdosed before, their future risk is significantly higher. And then frequent missed appointments can also be part of the opioid picture. This reflects instability, withdrawal, active use, maybe transportation issues, or life disruptions that are tied to their substance use. And then sudden sedation or slowed speech or appearing unusually difficult to wake up or rouse, that should prompt further assessment. And if it's really important to remember, red flags are not proof of one specific thing. They're just signals that you need to slow down. You need to assess more carefully and think about safety. And they're also going to help you prioritize your interventions. Like a client with repeated overdose history and maybe they have active polysubstance use, that's going to have a very different level of urgency than the client who's stable on MAT and engaging consistency. And then as a counselor, your skill is going to lie in noticing patterns, not just isolated moments. So a single sign may not tell you much, but when there's several signs together, that often paints a real clear picture. This is why opioid work requires careful observation, but we also need to do like detailed assessment and strong documentation. And the documentation in opioid cases is really important because the risks are so high and the clinical decisions are significant. So when documenting, we need to focus on objective observations. If the client appeared drowsy or had slowed speech or slurred speech, or they reported recent use, record that clearly and specifically. Avoid vague labels or conclusions that are not going to be supported by what you observed or what the client disclosed. And it's also going to be important to note overdose risk factors when they're present. So maybe this includes recent release from incarceration, recent detox, polysubstance use, fentanyl exposure, using alone, if they have a prior overdose history. These details are going to matter because they're showing the reason behind your clinical concern and what your response was. And then documentation should also include education. If you talked with the client about naloxone, or maybe you talked with them about fentanyl contamination, or maybe you talked about a loss of tolerance, you need to reflect that in your note. That shows that you address safety directly and it reinforces the clinical importance of the conversation. If you made a referral or a recommendation, document those clearly as well. So if you recommended a medical evaluation or a MAT consult or detox or emergency response, those steps should be included. And that's important for both the continuity of care and for professional accountability. Because good documentation doesn't guarantee good outcomes, but it does support good practice. And it's a CYA. It helps communicate risk clearly. It's supporting your decision making, why you made that decision. If somebody comes back and looks and says, this is what you did, why did you do it? They're going to be able to clearly see that. And it's going to record a record of your interventions. And in opioid work, where situations can escalate quickly, that level of clarity is going to matter a great deal. So at this point, it's going to be important to pause and check your understanding of the critical concepts that you learned from this lesson. So start with fentanyl. Can you explain why it's so dangerous? Not just because it's potent, but because it's often hidden in other substances and difficult for the client to detect. That combination of strength and unpredictability is part of what makes it so deadly. And then I want you to think about overdose risk after abstinence. Why does a period of sobriety or a period of treatment or detox or incarceration increase overdose risk instead of reducing it? That answer should bring you back to the concept of loss tolerance. That's one of the most important safety points in opioid education. Then I want you to review naloxone. Can you explain what it does and what it does not do? It reverses the opioid effects temporarily by blocking the opioid receptors, but it's not a substitute for emergency care, and it does not reverse non-opioid sedatives like xylazine. And then finally, I want you to consider depressant combinations. Why is mixing opioids with alcohol or benzodiazepines so dangerous? You should be able to connect that answer to compounded respiratory depression and reduced breathing. This is the kind of knowledge check that's useful because it's moving the information from recognition to recall. And in real counseling situations, you're not going to have the slides in front of you. You're going to need to understand the concepts well enough to use them fluidly, and that's what the goal here is. So I want you to apply the lesson to your practice. So think of a real client that you've worked with. Keeping confidentiality in mind, I want you to create a realistic hypothetical example. Identify the opioid-related risk factors that were present in that case. Did the client use alone? Have they overdosed before? Are they mixing the opioids with alcohol or benzos or stimulants? Have they recently been abstinent or released from incarceration? Then I want you to identify your clinical concerns. Be specific here. Are you concerned about overdose? Concerned about withdrawal? Maybe instability? Maybe a lack of understanding about fentanyl? Maybe they're ambivalent about MAT? And that's going to help you move from general concern to clear case formulation. Then I want you to consider what education would be most important. Does the client need to understand loss of tolerance or naloxone, or maybe you need to explain the danger of counterfeit pills? What information is going to actually matter the most in their situation? And then lastly, I want you to decide what referrals or recommendations might be appropriate. Would you encourage a MAT consult or a medical evaluation? Or does the client need harm reduction support or a higher level of care? This is important because opioid work requires constant application, not just general knowledge. You need to be able to look at a client's situation and quickly identify where's the risk? What are the priorities here? How do I respond? And practicing that thinking now is going to make you better prepared to do it in real clinical work. So as we come towards the end of this lesson, it's important to clearly identify the main takeaways that you need to carry into practice. First, opioids affect multiple critical systems at once. They reduce pain, they activate reward pathways, and they suppress breathing. And that combination, it helps explain both why they are reinforcing and why they are so dangerous. Second, overdose risk is high and often unpredictable. It's not only about how much someone intended to use, it's also about contamination, potency, tolerance, combinations, and also context. That unpredictability is especially important in today's drug supply. And then third, fentanyl and newer synthetic opioids have really changed the field. Clients may be using much stronger substances than they realize, and that means that the old assumptions about their dose or usual use are less reliable than they once were. And then fourth, a loss of tolerance after abstinence is one of the most important relapse and overdose hazards. Clients have to understand that returning to that previous dose after a time away can be deadly. And then finally, counselor education and referral matter. You're not the one prescribing naloxone in every situation, and you're not medically managing overdose or withdrawal. But your assessment, your language, your education, and your referral decisions are absolutely going to save lives. That's not an exaggeration. This lesson is one of the clearest examples in the course of why pharmacology knowledge matters in direct clinical work. So in the next lesson, we're going to shift from opioids to stimulants. And this is going to bring a different type of clinical picture. So instead of severe respiratory depression and overdose in the same way that we see with opioids, stimulant work often involves agitation and insomnia, maybe paranoia. They may be impulsive. It's going to cause cardiovascular strain, and the risk profile changes. But the need for careful assessment is going to stay the same. So as you're moving into that lesson, keep that same brain and behavior framework that you have been building throughout this course. We're still going to be looking at how substances affect the neurotransmitters, like how behavior is shaped by pharmacology and how risk is showing up in real life. The details are going to differ, but the structure of your thinking should remain strong. And this is part of what makes the course practical. You're not learning isolated facts about different drugs. Right? You're learning a method of clinical understanding that can be applied across substances. And that's what's making this information usable in actual counseling work. So take a moment to mentally close out this opioid lesson and notice what stood out to you the most. And then I want you to get ready to carry that same level of attention into the stimulant lesson. The content's going to change, but the clinical relevance is going to remain just as strong. And before you move on, I just want you to take a moment for final reflection. Think about what stood out to you the most in this lesson. Was it the issue of fentanyl contamination? Or was it the danger of lost tolerance? Was it the role of naloxone? The impact of polysubstance use? Identifying what stood out is going to help you notice where your understanding is deepening. And then next, I want you to think about your assessments. What are you going to change based on what you learned here? Will you ask more directly about overdose history or counterfeit pills or using alone or maybe recent abstinence? Are you going to ask more clearly about benzos or alcohol or mat involvement? These small changes in assessment can have a major impact on the quality of care that you're providing. Also, I want you to think about client education. What messages are you going to emphasize more now? Maybe you're going to be more direct about fentanyl. Maybe you're going to start talking more clearly about not using alone or the risk after jail or treatment. Maybe you're going to feel more confident discussing naloxone or correcting misinformation about MAT. Reflection matters because it's going to turn information into practice, and it's going to help you move from I learned something to I'm going to do something differently. And that shift is where professional growth is going to happen. So you've now completed lesson 4, and this is one of the most important foundations in the entire course from a safety standpoint. You've built a stronger understanding of how opioids affect the brain and the body, why they're so reinforcing, and why overdose is such a central issue in opioid work. We've looked at how fentanyl and carfentanil and nitazenes and xylazine have increased complexity and danger in the current drug landscape. And now we have a clearer understanding or framework for understanding the overdose risk factors. And that's going to be, we understand lost tolerance now and polysubstance use and hidden fentanyl exposure and using alone. And we also have a stronger understanding of naloxone and MAT medications and withdrawal and client education. These are not abstract ideas. They're just practical tools that we're going to use in assessments and treatment planning and direct conversations with our clients. And one of the most important takeaways from this lesson is that overdose prevention is part of the counseling practice. It's not outside your role to educate clients about safety or to assess for overdose risk and connect them with those appropriate resources. In fact, those actions are part of competent, responsible care. And as you're moving into the next lesson on stimulants, carry forward that same mindset that you used here. Stay focused on how substance affects the brain and how the client presents behaviorally, what the key risks are, and how your role is going to fit into assessment and education and referral. That's the thread that's connecting the entire course, and you're building it well.